So the question arises, why pterygoid implants? Why do we need pterygoid? So what was the requirement for the emergence of a newer technique for pterygoid? Number one reason is to avoid the distal cantilever. For those who are practicing implantology and those who all are doing full mouth cases, they know that it is very difficult with the distal cantilever. What are the drawbacks of distal cantilever? Can anyone, any guesses? Why clinician avoid distal cantilever, or even if we give distal cantilever, what happens? What is gonna be the outcome out of it? Any idea? No idea. So, in full mouth cases, the distal cantilever increases the occlusal load in the anterior implants only. So, technically, it will lead to the crestal loss in the distalmost implant placed. So, this type of cases has less longevity. So, we always ask for what is the rate of success. So, such cases, if we give distal cantilever and we load the cantilevers, so it's not gonna be a successful case for longer period. So, how can we avoid distal cantilevers? With the pterygoids. But why we are not doing pterygoids till now? Technique sensitive, or we can say it is a blind thing. We don't know where pterygoids are, how we can place from the oral cavity. So, by the end of this lecture, you will be trained for the flapless pterygoids. I bet you all. And another reason why we need pterygoid is to bypass sinus augmentation. So, not everyone can excel in sinus augmentation, or not every sinus augmentation will lead to a successful outcome. First you do a first surgery, sinus augmentation, then wait for 3 months, it passes or it fails, then you will plan for a full mouth case. Can patient wait? No. Can you risk such a long period of your practice into waiting for one patient after doing a sinus lift? So in such cases, we bypass sinus augmentation if you know a correct pterygoid. So if you can engage pterygoids and you put implants, as sir told, in the A region, so you are bypassing the surgical skill here. You don't need to do a further surgery over here. You don't need any bypass or graft surgery in the sinus region. So yes, we need pterygoid implant to replace the distal cantilevers and to bypass the sinus augmentation. And obviously, pterygoid implants increase the AP spread. It is anterior-posterior spread. Do we have any idea about AP spread? Why do we need to increase the implants anterior-posteriorly? So if you are doing all on 4, so implant will be till your premolar region, 4 or maybe 5. You can put a tilted implant and you can keep the abutment in max to the 6th region, but you can't go beyond 6 or 7. But pterygoid implant improves the AP spread. Benefits of AP spread: you can distribute the occlusal loads to the pterygoid pillars. So better occlusal load dispersion, better force distribution. So that is why 3 major reasons for pterygoid: to avoid distal cantilevers, number 1. Number 2, we don't need to do any sinus surgery. Number 3, it increases the AP spread, which is very important prosthetically and for longevity of a full mouth case. Then what is the fear of pterygoid? Number 1, risk. It is a very skillful technique. Number 2, even if we try to learn it, we are afraid of bleeding, we are afraid of visibility. So let's discuss one by one. We have a fear of pterygoids which is of limited surgical visibility. bone, and sphenoid bone is present in the midbrain. Even if we read about it, it feels like we are going into brain. Why don't we want to go? So it is risking. It is a risky thing. Next is limited mouth opening. In such cases, it is very difficult to do pterygoids. You can't even find. Or poor direct vision. Even if you open flap, it is present distal to the maxilla. You can't visualize pterygoids directly. So that is why till now we say that pterygoid technique is a blind technique. It needs a very skill, or maybe you'll grow older and older, maybe you're not able to excel the technique. So we omit. We learn treated implants and increase the little AP spread with the treated implants and never try for pterygoid implants. But for pterygoid, surgeon works with the tactile sense, and that tactile is a dip. A very similar dip in the root canal that we follow. So if you have found the pterygoid, when you are drilling, you will feel a dip, and that dip is the assurance point that you found the pterygoid and you are in the pterygoid. But I teach you step by step how to find pterygoid and where you will find the dip and how you will do a complete pterygoid engagement. And the most important, the biggest psychological fear, I'd rather say, bleeding. Out of 10, 8 doctors will not do pterygoid because of fear of bleeding, even if they know the pterygoid technique. Because of injury to pterygoid venous plexus, a possible damage to the maxillary artery, the middle meningeal, which passes from the upper and lower head of the lateral pterygoid muscle, or a hematoma formation, difficult access for pressure control. But this is a psychological fear. Even if it bleeds, I'll tell you in the end what happens. Bleeding happens when you are doing a pterygoid. And another major risk of sinus or nasal perforation. So if the sinus is too much pneumatized, we never try to go into sinus because of fear of perforation only. But when we will conclude this lecture, there shouldn't be any fear of any perforation in the sinus. Sinus is a very brave organ. It heals on its own. For study says, you can search on all the search kit and wherever you want to, you just type on Google how much the perforation of sinus membrane can heal on its own. Up to 5 mm of perforation into sinus membrane can heal on its own. And when we are drilling, we are using only 2 mm drill. And tip of drill is 0.6 mm only, the pilot drill that we are using. So if you perforate while drilling the sinus, no issues, it will heal on its own. That's the blessing of God or the sinus. Sinus is a good organ. We are just afraid of it. I don't know why. But after this lecture or this seminar or 2 days, we will not be fear of pterygoids or sinus or any other atrophied cases. We will not say no to any case, any patient that comes to us. And the most important factor is learning curve anxiety. We are only anxious to learn new things. And why? Because we think lots and lots of theory need to be there, lots and lots of knowledge, maybe lots and lots of 3D planning. So I asked one of my fellows, if you want to do pterygoid, what do you need to do? He told me you need to learn the proper CBCT reading, you need to learn the proper flap management, flap surgeries and all, and after that complication management. So that is why I am not learning, I am good with the other things that I am doing. We don't want to expand our aura of working. But with FX 1-2 technique, because it is a flapless technique and it is a minimally invasive technique, we will be able to restore all the full mouth cases without any surgery. But yes, pterygoids is a technically demanding. It requires 3D understanding of the anatomy. We read the anatomy in the first year of PDS, but we need to understand it in a 3D. That is why we will be doing a hands-on simulation on models so that you can properly visualize. After hands-on, when you are shifting your drills onto the patient, definitely you will feel the entire things like a good doctor. You will have an image here that where you are going, where your drill is going, have you reached the pterygoid, have you found the pterygoid, like that. So we will learn the pterygoid 3D anatomy and we will learn the technique, and we will first practice on the simulation, then on the patients, definitely after 2 days you will be able to do pterygoids. So pterygoid plate offers the thick cortical bone, excellent anchorage and high mechanical engagement. So it is the best anchorage pillar in the oral cavity, in the maxilla especially. And we'll learn a little about the anatomy. So maxilla ends, this is the distal wall of the maxilla, and from the distal, this is the pterygomaxillary suture where the pterygoid plates of sphenoid bone attaches to the maxilla. Here. So this is called the fusion zone. So basically in pterygoid pillar or fusion zone, 3 bones fuse. One is your distal of maxilla, this. Second bone is your pterygoid plates of your sphenoid bone. Third is palatine process of your palatine bone, which is the vertical process of palatine bone. Do we know that palatine is a separate bone? Palatine bone, it's a small bone present. I'll show you here. So medial pterygoid plate, it has a little significance before we start learning the surgical process. The medial pterygoid plate of sphenoid bone is a horseshoe-shaped process that arises from its underside. It is narrower and longer than the lateral pterygoid plate and curves lateralwards at its lower extremity into a hook-like process, the pterygoid humulus. So what we need to understand is the pterygoid humulus, because we will see this in the oral cavity while doing CTs, primary impressions. We take the impression of this humulus. So this humulus will guide us for the position of our pterygoid drilling. So that is why the important feature of medial pterygoid plate is this pterygoid humulus. The humulular process is the most prominent part of the medial pterygoid plate, which is easily palpable in the oropharynx. Lateral pterygoid plate of sphenoid bone is a thin, broad bone, everted and forms the lateral part of horseshoe-like process that extends from the inferior aspect of sphenoid bone and serves as the origin of lateral pterygoid muscle, which functions in allowing the mandible to open the jaw and move in lateral directions. So one of the another fear that if we do pterygoid, we might hit lateral pterygoid and have a trismus. This is treatable. You start proper medication and it will be treatable. But if you know the right technique, this will never happen. With me, with God's grace, I never did this. Because from the beginning, I learned the right technique and I'm practicing in the right way. But we should know the complications. That if you are doing pterygoid, बुरा से बुरा क्या हो सकता है? Bleeding, trismus, pterygoid plate fracture, sinus perforation, और क्या? Can we number all other complications that we can find by doing pterygoid? Nothing. And are these things treatable? Yes. So posterior view of sphenoid bone. So this is the medial pterygoid plate. This is the pterygoid humulus and the lateral pterygoid. And from lateral pterygoid the musculature arises, and the muscular tendinous significance here is that lateral pterygoid muscle, the lower part of lateral pterygoid is attached to the lateral aspect of the lateral pterygoid plate. From the first year BDS, I felt it so difficult to learn all the medial lateral pterygoid. I learned this after BDS. I tell you in a very simple way. Lateral pterygoid attached to the lateral wall of the lateral pterygoid plate. It helps in opening the jaw and sideways movement. Medial pterygoid muscle arises from the medial side of the lateral pterygoid plate, and it helps in the closing of the jaw. So there is a mnemonic. When we say medial, our mouth closes. That means medial pterygoid muscle helps in closing of mouth. Lateral, we open the mouth. So lateral pterygoid muscle helps in opening of the jaw. And superior pharyngeal constrictor, inferior end of the medial pterygoid plate, it is the insertion of this muscle. Tensor villi palatini, scaphoid fossa of the medial pterygoid plate. So only these 4 muscles are attached to the pterygoid plates. No other anatomical structure. Muscular anatomy. Lateral pterygoid, both the muscles have 2 heads. Lateral pterygoid upper head, lower head, upper head, infratemporal surface of greater wing of sphenoid, lower head, lateral surface of the lateral pterygoid bone, insertion, pterygoid and capsule of the TMJ. That is why it helps in the opening of jaw. Medial, it has a deep head and a superficial head. It is present medial to the lateral. That is why deep and superficial heads. And it inserts on the inner surface of angle of mandible. Here, on the inner surface of mandible. The pterygoid annulus has two important lesions, tensibillae palatini and pterygomandibular raphe. Lateral pterygoid process, sphenomandibular ligament. Only this is the muscular anatomy related to pterygoids. What is pterygoid pillar? It is a junction of maxillary tuberosity, pterygoid process of the sphenoid bone and pyramidal process of the palatine bone. This is medial lateral plate of sphenoid bone. This is palatine bone. And if we see on the distal, here, this is the distal of maxilla. So, one bone, two bone and three bone. This is the fusion zone of the pterygoid pillar. That is why it is the most strongest pillar and we get the greatest anchorage here. And pterygoid cortical is the third cortical because we engage in plant in the cortical of next bone or the adjacent bone. So, little clinical significance. Are we clear till here or is it boring? Because no one is speaking, no, yes or no. Okay. Still, if you are not, because I am not judge here or the examiner that I can ask questions what I taught. This is an interactive session and you are here, you are spending your 2 days. If you did not get any point out of it, that there is no meaning of sitting here. If you really want to learn pterygoid, ask questions and understand the concept. I try to make it as simple as possible and we will discuss only the clinical factors. We discussed the muscular anatomy. Now we will discuss the dimensions of pterygoid. Maybe we skip this all the time we go through the basic anatomy. So width of magnet, because when you know the diameters and the length and width, then only you will be able to plan for pterygoids easily and effortlessly. Width of magnetic tuberosity, which is this. Distal to the third molar. The range is 11.02 mm to 22.61 mm. The range, and we take mean population as 16 mm of it. So the width of this area is the fusion zone is 16.52 mm. And width of pterygoid process, it is lesser than this. We can see if this is the distal of maxilla and pterygoid width is lesser than that, and that ranges from 7.3 to 15.68, which means to 11.60. It means we have a width of 11 mm. Or if we even, because this is a safe zone, if we even shorten it, let's take it 8 mm. So are we able to place implants here? When we are navigating pterygoid, when we are drilling it with your drill, so you have a lot of room to navigate your pterygoid. Height of maxillary tuberosity ranges from 1.23 to 13 point. Mean 7.4 and 5 mm, but it depends upon resorption pattern. Because after the exfoliation of the teeth, the maxilla goes into resorption, so this height will definitely reduce. But this is the average, that 7.45 mm of height is there in the mean average population. And length of posterior maxilla extends from lateral margin of pterygomaxillary junction till the root of zygoma. It is 21.94 mm to 32.77, ranges to 27.18 mm. But we know that there is a vascular or anatomically soft tissue structure which is here, which is pterygomaxillary fissure, in which all the ganglia, your nerves, and the entire maxillary trigeminal nerve and maxillary artery, everything on here. So that is why 27 is present, but safe zone is 13 mm. This is the key point to note here, that even if we have 27 mm length available, we will not think that we can put n number of implants, but 13 mm of height is safe zone. So this I'll discuss later on. The another vascular structure which is related related to the pterygoid is that should be kept in mind while planning cases. The internal maxillary artery emerges from the external carotid artery at the subcondylar level and passes into the anteromedial region deep into condylar neck of mandible into the infratemporal fossa. It divides into three parts: mandibular first part and pterygoid second part, and we will see the second part. The external carotid, this is the second part which passes from the, which is the middle meningeal, which passes from the upper and lower head of the lateral pterygoid plate. Between the two heads of maxillary artery usually passes between superior and inferior head along with buccal nerve and traverses the head to enter the pterygomaxillary fissure. अभी आफ्टर दिस मुझे ऐसा लगता है कि इतना वैस्कुलर स्ट्रक्चर सबसे इंपॉर्टेंट आर्टरी और नर्व यहाँ पे पढ़ लिया, अगर टेरिगोइड करेंगे इनको हिट होगा तो फिर शायद हम फिर टेरिगोइड ना करेंगे. बट द टेक्निक से यहाँ तक तो हमने जानना नहीं. दैट इज व्हाई वी लर्न ऑल द रेंजेस ऑफ डिमेंशन दैट वी गोना यूज. वी शुड नो द एनाटॉमी बट वी नो दैट टेरिगोइड्स आर द सेफेस्ट इम्प्लांट टू प्लेस blindly. And another fear of hematoma, because on the lateral surface of the lateral pterygoid wall, we have a pterygoid vein plexus. The bleeding, the hemorrhage, the hematoma that happens is from this only. But this is an anatomically closed surface and this is a venous blood. So it can be controlled with pressure, and as it is an anatomically closed area, so the blood will stop on its own, even if you rupture the venous plexus. So that is why the next we will learn the main thing, the very main thing. Be alert. अभी तक अगर नहीं सुना implant करना तो आप सीख लोगे. For pterygoid implant placement, you need to learn the two angles, the vertical angle and the horizontal angle, which is also the buccopalatal angle. And vertical angle we can call it a coronal angle, like how much occlusal tilt you have to give while doing this. So if you are using the right angle, you will never rupture any artery, any muscle or any vein. So vertical angle 45 to 55 degree. It is the mean average set by that this is the mean. But it is not in all the cases. So how you will figure out in your cases that what is gonna be the vertical angle when you are placing implants. 45 to 70 degree to the maxillary occlusal plane. Typically 55 to 65 is the most commonly used, but it changes with the resorption pattern. Direction posterior and superior, aim towards the annular notch region. That it means not go distally. So if this is your horseshoe shaped ridge and we are so this is your first segment. So when you are placing pterygoid, so your vertical angle will be this. If you are going distally, that is why it says towards annular notch. That you have to go palatally, not distally, because distally ही आपका vascular structure पड़ा है, आपका venous plexus वहीं पे है, and your muscles are there only. So if too shallow, you will not engage. If this angle is too shallow, maybe take here, you will not engage the fusion zone. So target in pterygoid is pterygoid fusion zone. Just as a nasal floor was the target in the inferior region, in C region, in pterygoid region, our target is to go into the pterygoid fusion zone. So if your angle is too shallow, you will only keep your implant in the tuberosity. So where mistake happens because you can't take OPG while doing, not everyone has OPG. So when you are placing corticals, you do a lesser drilling. So those who are doing the low, you are drilling 2 mm and you are placing 3.5 mm implants, because your threads of the implant are self-cutting. And self-cutting threads in the cancellous bone, you feel a pseudo torque. You think that it is, the torque is 60 or maybe infinity. I think I am in pterygoid, but that's not the pterygoid. How you see that you are in pterygoid? From this sound. You tap the head of your implant. If it is metallic sound, that means you have crossed the pterygoid. When you are in cancellous bone, you will never feel that sound. And this particular thing we'll see in the practical today in the patients, and tomorrow in a full large cases we will do pterygoids. So too shallow angle, you will leave your implant in tuberosity. If too steep, you may go into the pterygomaxillary fissure. So that is the big issue that we put you in risks. So that is the only risk. So pterygoid means not a vertical angle implant in the posterior of your maxilla. Pterygoid means a minimum 45 to 50 degree angle. Never goes more than 70. We can judge by our eyes that Are we going more than 45 or 70? Never vertical, keep it in the middle of 45 to 50. So I teach you in the OPG. So for pterygoids, till now, do you think that only CBCT is required to teach, to know the pterygoid? Can we see pterygoids in OPG? And can we plant pterygoid implants with OPG only? Yes or no? Yes, with OPG. So ma'am, can you please tell me that how can we find pterygoids within this OPG? Just a general idea. Behind this? Yes. So this is pterygoid. So it is pretty much clear in the OPG that this is your tuberosity, and just beyond your tuberosity, this flat shaped thing or angle shaped thing is your pterygoid, and in this lateral pterygoid, and this is the medial pterygoid. So maybe not all of you can justify, because this after learning, seeing X-rays, maybe you will be एक आंख बंद करके बताते हो हाँ pterygoid यहाँ पर है pterygoid यहाँ. So the basic thing, the basic rule that you need to follow while judging pterygoid is, we all know tuberosity. Move beyond the tuberosity where the distal of your maxilla ends. Here is the filling zone, and any flat shaped thing that you find here is a radiopaque is your pterygoid. Likewise here. And if you trace this distal of your maxilla to upper, a teardrop shaped lucent thing on both the sides bilaterally, it is your pterygomaxillary fissure. So this totally tells that what will be your vertical angle. So with this, here in the OPG, you will be only able to understand the vertical angle. You will plan that your implant will be here, and I will show you how. This is your tuberosity, your pterygoids, and this will be your vertical angle. This is the exact same thing you will do in the patient. Next, trace the tuberosity. This is the distal of maxilla, this is the pterygomaxillary fissure. These are the pterygoids. I have already marked them. Can you appreciate this? Are you able to see the pterygoid plates? Because not, then you will not be able to do independent cases. Until tomorrow we are there, we'll tell you. Maybe we'll hold your hand and let you know, but after that you need to do it yourself. And this will be your vertical angle. And now we can very well justify that vertical angle was little shallow in the previous X-ray and little more vertical in this X-ray. So vertical angle completely depends upon the patient's anatomy, and you should be able to read OPGs properly. So it is more vertically. I'll show you the after OPGs as well. So this case, we trace the tuberosities and we find the pterygoids very high. So definitely our vertical angle will be more steep. Let's mark it. Your pterygoids. And more steeper your vertical angle. So if we compare three of the X-rays, the vertical angle, so that's what I want to show you, that you need to plan your case on your own, and every vertical angle is planned with this least effort. Horizontal angle. Are we all clear with the vertical angle? Because emulation, फिर मैं जज बन जाऊंगी. Then I'll only ask. I'll let you drill on the models. जिसने गलत किया, they will not be allowed to practice in the surgery. Done? Deal? Okay. So we'll learn the horizontal angle. So horizontal is the buccal angle of your drill or your implant placement. So I told you that Handler process is this greater significance in planning horizontal angle, because OPG will not tell you that what will be your horizontal angle. This you have to judge clinically in the patient's mouth. So this is the horizontal angle. This is the angle with the, if hypothetical line passes through the center of the ridge and the angle of your drill with this hypothetical line is your horizontal angle. And for planning horizontal angle, you need to learn two things. One is your resorption pattern of maxilla. The maxilla resorbs inwards. So in resorbed cases or in edentulous cases, your horizontal angle will be less because the maxilla shrinks. And in dentulous cases, when you are extracting it, definitely your pterygoids are more inwards. It means inwards means more palatine, then your horizontal angle will be more outwards. If it is 15 degree in the resolved cases, it could be 30 degree in the dentulous cases. Pterygoid handlers, so how you will plan? So in the oropharynx, you find this very sharp thing here. So you will feel this, you will pat this angle, definitely you will take your drill into the direction and you will start tapping the pterygoid. So for tapping, there is another instrument I will show you. But what we need to learn is this: you should be able to palpate this, and we will be going parallel to this. Keep your drill here, move parallel on the ridge, and if you dig, and there you stop, decide your vertical angle, and when you dip in, definitely you will find pterygoid. And आप खाली ड्रिल से इसको करते हो, there is a handle, उसके ऊपर आप normal अपने average drill with which you are drilling, you put that drill over it. आप tuberosity is a very cancellous mode, very spongy, आप हाथ से उसको perforate करते हो. When you perforate it and you reach the pterygoid pillar, the fusion zone, उसके आगे आप अपने hand pressure से नहीं जा पाओगे, and that is pterygoid tapping. with जहाँ पे जाके आप ऐसा करते हो, you push your pterygoid handle into it and you will not be able to push it beyond that. It means आपको ऐसा दीवार जैसी resistance feel होगी. It means you have found the pterygoid. Remove in the very same angle. Remove your drill, your handle. Put your drill in and start drilling very slowly with in and out motion. You will precisely find the dip. Where you find the dip, it means you have perforated your pterygoid. Keep the direction same. Take out your drill. Put your implant. Screw in your implant. You're good to go. Then tap the head of the implant if it is dull metallic sound, and you have achieved the desired optimum 70 to 80 Newton torque. It means you have perfectly engaged the pterygoids. So how resorption, maxillary tuberosity resorption helps you find the horizontal angle. So in unresolved case, the pterygoids are more inwardly placed. Your angle with the hypothetical line will be more. Then there is a resorption. Your drill goes parallel. In a very severely resolved cases where there is a class 3 relation in severely atrophic ridges, your drill almost goes parallel to the hypothetical line. The key point or the takeaway point: never go distal. If you go distal, there is a venous plexus, there are pterygoid muscles or arteries, then there is a hollow space where we give the PSA block. So always keep palatal. So in the horizontal angle, it should always be palatal, never in the distal direction, never in the opposite direction. And never too much palatal because you're creating palatine arteries and nerves are moving there. So you might rupture that as well, but only bleeding will happen and you'll be able to control bleeding. But when you know the right technique, why you wanna rupture GP or the plexus? So are we done with the horizontal angle and the vertical angle? Any doubts? Because after this, I'll teach you one more thing and we are going to go to the pterygoid. And we'll start with the hands-on. Third point is approach point. Now you know the vertical angle, horizontal angle. किसी ने पूछा ही नहीं, शुरू कहाँ से करना है, एंट्री कहाँ से करनी है tuberosity में. Very simple, in a very simple manner, I have evaluated in utensilous cases from your tuberosity 8 to 10 mm front में आके आप to start. वहाँ से आप अपना horizontal angle decide करो, vertical angle decide करो, with your handle find the pterygoid, and if you have an immediate extraction, तो आप हो गया. फिर lottery type case है, because in immediate extraction it is very easy to find pterygoid. What you need to do is distal wall third molar. आपका socket है 8 का, उसके distal wall में if you put a drill in, सीधा सामने का pterygoid, good to go. और उसकी measle रूट से अगर आप लेते हो, you will find the second pterygoid भी वहाँ से. Approach point, vertical angle, horizontal angle and approach, मतलब entry point. We are done. We all know. उसके बाद next is osteotomy preparation. We can, in initial cases, we can verify the relation with IOPA. You can take your sensor very backward and you can see the angulation. And use a 2 mm lance drill with 1:1 straight handpiece. For corticobasal, the basic principle is always 1:1 handpiece drill at a higher speed. But in initial cases, you can start with a slower speed. Because cortical bone is a deeper bone. Till then, no irrigation goes and heat necrosis can happen. तो आपको बहुत मैनेजेबल वे में 1:1 आप फास्ट स्पीड यूज करते हो और सेकेंड यू ड्रिल एंड कम आउट. जैसे कन्वेंशनल में फॉर ऑस्टियोटमी प्रिपरेशन इट टेक्स आई थिंक 1 minute to 1.5 minutes आई बिलीव. बट इन कॉर्टिकल अब भी आफ्टर दिस सेशन एंड विल टेक 2 patients, so ऑस्टियोटमी डन. ओनली थिंग इज योर प्रिसाइज. जिनको आरसीटी अच्छे से आती है उनको डिपर अच्छे से फील होगा. बट आफ्टर जिनको आरसीटी नहीं भी आती सबको अच्छे से फील होगा. यू विल बी एबल टू फील द precisely feel the dip in the nasal bone, in the mylohyoid, in the pterygoid region, in the palatal bone, everywhere. Not palatal bone, palatal-nasal. Excessive pressure, rely on drilling speed for a controlled cortical perforation. This is all technical. When you are drilling, so okay, that's fine. We shouldn't put excessive apical pressure while drilling. Drill moves on its own. It will keep creating its area. You just go in and out so that irrigation, your external irrigation goes into the and no heat necrosis happens. Once resistance drops, it means dip sensation is felt. The pterygoid plate has been successfully penetrated. This you will better understand in the hands-on session. So this is nothing. This is one handle in which you can hold your drill, the basic 2 mm long lance drill. उसमें अच्छे से attach होता है. I'll show you every arm that I'm talking about. So this is how you palpate. Here could be some हमारा hemular process. हम उससे we went distally on the center of ridge. I decided my vertical angle and the horizontal angle, and with this hand instrument we will find the pterygoid plate and we will perforate it with the drill only. I have one video. Done. वीडियो जितने में आपने आंखें उठाई उतने में तो ऑस्टियोटमी हो गई. Minimally invasive, no bleeding, no trauma. What else do we need? What else patients should need? So it was the drilling for second implant. So in the same osteotomy, we engaged the implant. Before this, single implant or double implant, ये कैसे decide करना है? I would like to ask, everything is okay? I think everyone is traumatized. I believe there shouldn't be any to tell you that how pterygoids are easy. Every 55 of you will place pterygoids, I know. And I'll give you my number, you have to share your cases, especially pterygoid cases, OPGs. I'll check. So the question arises, single pterygoid or double pterygoid? Triple B होते हैं, but let's keep it in single or double. How we will decide that are we going to go place single or double? इसके दो clinical parameters. One is the clinical parameter, जो simple भाषा में, which is the span length. If you have placed 4 implants anteriorly and you have placed single implant in the pterygoid region and you are unable to place any implant in the sinus region, definitely you have to go for the 2 implants in the pterygoid. If not to, then sinus management you have to manage this region because you can't leave the span this big. Again failure. Why failure happens? Lesser planning, lesser execution. You have placed perfect 4 implants anteriorly, 1 posteriorly, but the span is more than 10 mm. How is the duty of your case you can plan? Again the entire district pressure will go on this anchored implants. So one parameter is you will decide with your span length. Another is very important, posterior sinus pneumatization. So this is very important. So this is part classification for pterygoid implant specifically. This is pterygoid anatomic radiographic prediction given by Louis et al. It was based on the extent of maxillary sinus invasion and the consequently available width of bone in the pterygoid region. With some diagram in the next slide, I'll tell you. This is basically the length of bone available from the posterior wall of sinus to the distal wall of your maxilla. The amount of available bone. So there are 4 classifications. Part 1 says if your length between your posterior wall of sinus and your distal wall of maxilla is 15 mm, then it is part 1 classification. Part 2, if it is 11 to 15, part 3 it is 5 to 10, part 4 is 5 mm. So less than 5 mm means your sinus is almost in proximity with your fusion zone. So one implant that you want to place in pterygoid is going to be transsinus again. Transsinus is easy, आप जा सकते हो sinus में छेद करके वहाँ पे implant डाल सकते हो. Why? Because cortical implant is a smooth surface implant. So while buying implant, you need to see that implant should be smooth surface. Because basal implant नाम से rough compressive implant रहते हैं. If you put that implant transsinus, it will lead to the problem because rough surface, infection, no sinus healing. So when implant is smooth, your sinus perforation, even your implant, if it is lying in the sinus, it won't hurt sinus. So this is second implant. We will place, if we have placed the first implant, second implant will be parallel to first and 4 to 5 mm anterior to the first implant. We can place it in the from the tuberosity or transsinus. So this implant 1 and 2 both are in the tuberosity into the fusion zone. This one is in transsinus. So look, we went perforating the sinus and into the fusion zone. So if you have achieved the primary stability, which is the initial torque, it means you are good to go. But you should engage it bicortically. क्योंकि सूडो टॉर्क का भी मैंने एक पॉइंट बताया था, tuberosity में भी टॉर्क बहुत हाई फील होता है. So then tapping your implant is very important. So FX12, a minimally invasive plus surgical approach for implant placement in the pterygoid region. You can see no bleeding. हमने इसकी वीडियो देखी है. There is no bleeding, no pain, no flap, no nothing. And we successfully placed 2 pterygoid implants. And now discuss all the cases. I think not discuss, we'll see the outcomes. Tuberosity, pterygoid, definitely vertical angle will be little shallow, not vertical. And what will be the outcome? This. 1 implant, 2 implant. So when conventional is there, so it is multidisciplinary approach. So this happens when you are a clinician and you have to plan certain things patient-wise. Another case, way too much pneumatized sinus, definitely a zygoma case, but with the magic of bicortical or S665, we can still manage this without zygoma and feel how happy will be a patient after this. कि उसको zygoma वाला implant नहीं करना पड़ेगा. So this is the tuberosity, and definitely we can appreciate these are the pterygoid plates here, and we will see the results. 2 pterygoids, 3 implants, 4 implants, so that then we place this in the palatal bone. We are fulfilling FX12, we have fulfilling S665 technique. So both the techniques are helping us beautifully in restoring all the the rejected cases. Another case, another failed case of conventional. Sir already shown this. So high pterygoid, this is the case of high pterygoid where you failed. So this was the scene when patient came in. Patient खुद से इसको अटका के रखा हुआ था 3-4 दिन से. So we moved it. We went for the zygoma because there was no bone in the sinus. यहाँ पे तो sinus खुला ही हुआ है. So this is the case of high pterygoid. Another case, tuberosity, pterygoid, tuberosity, pterygoid. If you mark your pterygoid here, one we can place again, but again clinically depends what we will be able to do. Two pterygoid, single pterygoid. Perfect strategically placed implants. Another chronic generalized periodontitis case, we extracted all the tooth and restored the case. So after learning both the technique, we can do immediate functional loading. So immediate loading and immediate functional loading both have a different meaning. For the success of immediate functional loading, you need to check the primary stability, you need to check that your implants are osseo-fixated, and implants are only osseo-fixated in the cortical bone. So if you are in basal bone, your implants are not osseo-fixated, you cannot functional load your implant. Even immediately, even on later period, that will not sustain. But still smooth surface implants are titanium. Titanium is osseo-inductive. Osseo-integration will definitely happen, and we will go on. And then is the cross-arch stabilization, which is tying your all the implants from one end to the other end of your oral cavity. Primary stability is the mechanical stability at the time of placement achieved by dense cortical engagement, bicortical anchorage, and proper under preparation. So if 3.5 mm implant, drill for 2. Torque more than 40 to 50 centimeter torque indicates strong mechanical interlocking in the dense bone, like the pterygoid plate. Higher the torque, better resistance to functional loading and controlled micromotion. Most feared complications: bleeding from pterygoid venous plexus, but it is venous blood, can be controlled with pressure. Severe life-threatening hemorrhage is rare when proper angulation is maintained. So when you are able to judge your vertical and horizontal angle, this will never happen. Sinus perforation, it could happen. So we are taking this trans-sinus approach. So it means sinus is not the obligation or the object in our or hurdle in our path. We can go with the sinus, we can use sinus for the anchorage as well. Perforation up to 5 mm of sinus membrane is self-healing. So here I am completing the class. So this is our academy, where more than 50 courses we have conducted pan-India and out of India with complete hands-on training on patient. Less than theory, more we focus on hands-on placement. Each candidate places implant. We give proper prosthetic training, and at various colleges we have given hands-on training to the postgraduates and undergraduate students, and sometimes to the faculty of the colleges. Because corticobasal, it is not a newer technique. It has not been practiced. So thank you. Allow yourself to be a beginner. No one starts off being excellent. सब बच्चे से बड़े हुए हैं, बड़ा तो कोई भी पैदा नहीं हुआ. So one day you have to start, and that will be the beginning, and with every passing day we'll improve and we'll learn more things from each other and from ourselves as well. Thank you everyone. And any questions? Because right after this we are moving to our hands-on session.
Any questions?
Everyone is sleepy.